All right, let's see if I have done it. Shut out. All right, so these are the cardiac drugs that they'd like me to speak about. I'm going to spend a fair amount of time on the first group, the sort of non-specific antihypertensives, although we can group them pretty nicely together because they all cause, surprise, surprise, hypotension. um, but there are some specifics we can talk about, and then the beta and channel blocker, calcium channel blockers, and cardiac glycosides. I will review after those. I feel like we talk about those a lot, but they also could be, lots of questions on your test. So let's do it. I'm going to just go through. There's about 8 different antihypertensives. In yellow are the examples of those. The first is the peripheral alpha 1 antagonists. So, like, I think prazosin is probably the most common that we see. These cause smooth muscle relaxation. Surprise, surprise. They do that in arterioles, so that's why we use them for hypertension occasionally. But they also do so in other areas of the body, and prazosin, I think, is most commonly prescribed for dilating the urethra in people with benign prostatic hypertension, benign prostatic hypertrophy, not hypertension. I don't even know what that would look like. Although it's kind of technically put under this antihypertensive, it's commonly not used for that. So the overdose toxicity is hypotension, no big surprise. I would, treatment was going to be IV fluids. I think because these are alpha 1 antagonists and alpha agonists seems like the most reasonable thing, titrate to effect. So phenylephrine is probably the drug of choice, although obviously there's lots of other vasopressor options for you. They can get hypotensive and tachycardic because there's nothing stopping them from having a reflex tachycardia. And that is true of most of the antihypertensives, the non-beta blocker, calcium channel blocker, the ones that don't have an effect on the heart. All right, let's see. ACE inhibitors, I have a list of, I think, all of the ACE inhibitors there. These are also smooth muscle relaxation, specifically inhibit the conversion of angiotensin 1 to angiotensin 2. Angiotensin 2 is a potent vasoconstrictor. So this really are inhibiting the production of a vasoconstrictor and therefore causing vasodilation. A little bit of a roundabout way of going about it. But I think in general, most of these overdoses are pretty benign and they don't have a very high rate of hypotension. However, challenge accepted, you certainly can take enough to get hypotension. And I think it's becoming more and more evident that these are a significant factor in combined overdoses so that they're contributing to hypotension. And when they're combined with another hypotensive agent, they have a much higher rate of hypotension. So, and again, I think it seems reasonable to me, these, if they get hypotensive, they'll probably get tachycardic. So something like phenylephrine, IV fluids first, but then phenylephrine is probably your agent of choice here. Now, as you know, ACE inhibitors have this other toxicity that we see occasionally, or we hear about occasionally, and that is ACE inhibitor angioedema. This is a patient with ACE inhibitor angioedema. You see the tongue is absolutely enormous. This happens because the ACE inhibitor itself, leads to an increase in bradykinin that leads to increase in interstitial fluid, so capillary leak. The really interesting thing about these cases is this person has just tongue, it can be lips, it's usually around the mouth and throat, unfortunately. But that tongue is soft and cool, as opposed to most areas of swelling, which are inflammatory. And so every once in a while, we have these, kind of questions about like, could it be ACE inhibitor angioedema, or is it like, a tongue infection or, something like that. These tend to be very, very cool. So it's a little bit weirder, it's harder on the tongue, but on the lips or on the face, that'll be really soft and doughy and cool. Not like swelling usually is. Swelling is usually warm to the touch because of the inflammatory mediators. So what's the treatment? Well, there kind of is no treatment. We do a bunch of things. Obviously, if somebody's throat is swelling, then they need to be intubated. This picture of this patient, this person ended up getting a nasotracheal intubation because you can't get into that mouth in any way. There is some evidence of giving FFP may decrease some of the swelling. There are newer, I shouldn't say newer because they're kind of old now, but kallikrein inhibitors that are designed for hereditary angioedema that may work. There's a little bit of evidence that they do work. Unfortunately, they're really, really expensive. So they're not very commonly used, but they can be, and the names are there. So again, they're designed for hereditary angioedema, but can be used in ACE inhibitor angioedema. And I suppose I have to check again to see what their prices are now, because I think they've come down. But I'd say FFP is probably your answer if you got that question. Now the ARBs are the next step. So they don't inhibit angiotensin production. They just simply block the angiotensin receptor. So again, same mechanism, vasodilation. Their side effect would be hypotension. And again, phenylephrine would probably be your drug of choice. There is, interestingly, for any of these, you could consider something like methylene blue for ACE inhibitors or for ARBs. I haven't had a case where they got really, really hypotensive yet, but methylene blue. So still 14. That's actually so $1,400 is not that bad for considering the. Yeah, interesting. I think it used to be like tens of thousands of dollars, and that's why it wasn't really adopted. But thank you, Mark. So methylene blue, there is some evidence that part of the effect of ACE inhibitors and ARBs is nitric oxide related, which methylene blue can act as a scavenger and decrease nitric oxide. So I think anyone with refractory hypotension, if you ever see an ACE inhibitor or an ARB that has refractory hypotension, well, I want to know about it because I've never seen it before, but it's a possibility. So I wanted to add it in there. All right, so very rarely used as antihypertensives anymore, clonidine. Yeah, there you go. So 17,000 is more along the lines of what I remember. That's one of the kallikrein inhibitors. So they're listed as antihypertensives. They can cause hypotension. They're not usually used as antihypertensives. Clonidine, guanabenzine, and guanfacine, those are most commonly used for ADHD at this point. Dexmedetomidine is an IV sedative agent used in critical care units. And xylazine, of course, is an agent that comes up when you're talking about adulteration of fentanyl. Mostly and otherwise, it's a veterinary sedative, much like dexmedetomidine is. All of these decrease sympathetic outflow as the cause of their um, uh, uh, as the mechanism by inhibiting central alpha 2 receptors. So, you can see why they're not great antihypertensives because the only person that they would work on is the person who has hypertension because of sympathetic outflow. Everyone else, it really probably is not going to work particularly well. Most of these agents are also imidazoline receptor antagonists, and that probably has a lot of the effects of hypotension and bradycardia in these drugs. And one of the reasons why this might be important is xylazine really has alpha 2 effect, but very little imidazoline effect at all. And so, overdoses of xylazine have typically caused CNS sedation with very little bradycardia and hypotension, but of course, we don't have a huge amount of experience on those yet. But I think that's the case with clonidine overdoses, right? You expect this antihypertensive to cause this really severe refractory hypotension, and 9 times out of 10, the person is just CNS sedation, and that's it. But it certainly does. Hypotension bradycardia can occur, and so have to be prepared for that, of course. So treatment, intubation if necessary. There is some debate, particularly on clonidine overdoses, that high dose naloxone can reverse it. There's one retrospective study that seemed like it was pretty effective. So 5 to 10 milligrams IV. I think obviously you have to determine that the patient does not have opioid use disorder or use large quantities of opioids, because that would be a high dose of naloxone. But I do think it's a reasonable thing to try, and I think the evidence isn't huge, but it does seem to be effective in some cases. So if you're about to intubate someone, I think you can give a trial of naloxone. If it doesn't work, you intubate them. If it does work, then great, we've avoided that. But I think there could be a question on that for sure. It's a little controversial, but I think it could be there. And then everything else is obviously supportive care with vasopressors and IV fluids. Diuretics, we don't see a lot of overdoses of diuretics, or at least we don't see a lot of them. They get really sick. These are the different types of diuretics. I think in general, my experience with diuretic overdoses is that usually nothing happens. And then every once in a while, somebody takes enough that they start getting really, they start having really, really increased urine output. They get dehydrated and they get electrolyte abnormalities. And you can see the long list of electrolyte abnormalities that can happen with these. And then the one exception to all of this big long list is that some of them can get hyperkalemia, particularly the potassium sparing diuretics like spironolactone. So, and then I kind of grouped the loop and thiazides together because they kind of cause the same thing: dehydration, hypo-K, hypo, lots of stuff. And then the potassium sparing diuretics, hyperkalemia. And then carbonic anhydrase inhibitors are rarely used, but decrease the reabsorption of bicarbonate, so you get a metabolic acidosis. But in general, hyponatremia with hypo or hyper-K, the treatment is really just repletion of the thing that's lost, and with IV fluids and electrolyte repletion. I did just put in here that, did it say antagonists? No, it should be agonists, right? I always get that confused, so I'm not surprised that not surprised that I would make that mistake. I just put a note in here about sodium correction. There's a lot of concern about rapidly changing someone's sodium. That is usually not in an overdose situation. So if someone has been overusing their diuretic for a month, and they have hypernatremia or hyponatremia, or then they should be corrected very slowly over days. The general rule is don't change their sodium by more than 12 per day, 12 milliequivalents per liter per day. So if they're at 100, then you want them at 112 tomorrow, 124 the next day, 136 the next day. So it's going to take you 3 days or longer to fix their sodium. If it was an acute overdose and it happened really, really quickly, then it doesn't matter and you can rapidly correct them. But it is important if it's a chronic use or if their sodium went down slowly that we don't correct them too quickly. All right, last group, direct vasodilators. They usually cause some nitric oxide release, and that's the mechanism for why they vasodilate and why they cause hypotension. And again, I think the drug of choice here is, drug of choice is phenylephrine. All right, let's move on to the calcium and the beta and the cardiac glycosides. So I think they'll be a little bit more likely to be on your test. I don't, the sort of antihypertensives that aren't in those groups are much less common and are much less severe. So the calcium channel blockers are broken down into dihydropyridines on the right side here and the non-dihydropyridines on the left side. Thankfully, we are seeing less and less and less of these drugs being used. Unfortunately, they're being replaced with this one right here, amlodipine, which is also problematic. But the most of the calcium channel blockers, obviously, most of them come in extended release or extended, XLSR or something like that formulations at this point, because most people don't want to take medications multiple times a day. And the onset is very, very quick with the immediate release, but we're seeing those less and less often. And most of these will have a peak, 6 to 18 hours later. Half-lives are all pretty similar with the exception of the 3 listed there, amlodipine being the big exception, which is extremely long half-life. And of course, obviously in overdose, half-lives can be prolonged. So calcium channel blockers block L-type voltage sensitive calcium channels. Don't think that'll be a question on your test, but there have been other types of calcium channels with calcium channel blockers. And the common ones that we see block L-type. So I've said it out loud. Hopefully you remember it in case they ask that. I don't think they will. But they cause vasodilation, so hypotension. They cause decreased contractility, so hypotension, bradycardia and AV block, and they may lead to hyperglycemia. So let's go through a couple of those mechanisms because I think it will help understand what treatments we give for specific patients. First is just think about vascular smooth muscle. So this is muscle that is around an arteriole in an end organ. And what typically happens is calcium enters the cell through a calcium channel, and then it does its thing with myosin light chain kinase and causes a contraction. So the point being here that in smooth muscle, it's the calcium that enters the cell that actually causes the contraction. And this will become an issue when we talk about giving calcium to increase blood pressure, because increasing the calcium will increase the amount of calcium that enters the cell and increase contraction. So calcium channel blockers block that channel and then obviously lead to vasodilation and hypotension. Now it's a little bit different in the myocardium. In the myocardium, sodium comes into the cell, causes a depolarization, which opens up calcium channels, which then cause calcium-mediated calcium release from the sarcoplasmic reticulum. So the calcium entering the cell is not the calcium that's causing the contraction. You just need a little bit of calcium to enter the cell to cause a lot of calcium to leave the sarcoplasmic reticulum. And so it's a little bit of slightly different mechanism. And so the treatments may be a little bit different. And so less calcium in, less cardiac output. And then the pacemaker cells, remember I showed you action potential before for the ventricular and atrial cells. This is for the pacemaker tissue. The stuff that's coming into the cell is calcium. It's not sodium like it is in the atrial or the atrial and ventricular cells. So a decrease in calcium flow will lead to a slower entrance of calcium into the cell, and will slow down the heart rate, or if it's in the AV node, will slow conduction. And that obviously leads to bradycardia and AV block, and there's no change at all on the QRS or QT intervals because this has nothing to do with calcium. The slight amount of calcium that is coming into the cell is the stuff we already talked about entering the cell to cause the calcium-mediated calcium release. All right, so what do we do for a big calcium channel blocker overdose? So would we consider orogastric lavage? Sure, it would have to be really big, and I would have to be really, again, my feeling on lavage is like, if I think the person's going to die no matter what we do, then I will strongly consider it. But if I think it's an overdose that we'll be able to handle just fine with the treatments that we have, then I would not. Activated charcoal, certainly, and especially with these extended release formulations, I would probably give it much later than the typical 1 to 2 hour after overdose, but maybe give it as multi-dose as well. And then, of course, the true ghost pills seem like they're tailor-made for whole bowel irrigation. So let's talk about targeted treatment for bradycardia and then for hypotension. So bradycardia atropine. Atropine is a temporizing measure. It always has been. Lasts maybe 20 minutes. The role of atropine in my eyes is to increase the heart rate long enough so that I can do something to fix the problem or to treat it long term. So atropine is what you do at the bedside when you get that heart rate up in order to get your epinephrine infusion or your pacemaker or whatever it is into place, because atropine is not going to last all that long. Bradycardia can be treated with beta agonists, specifically epinephrine. There's lots of other beta agonists, of course, and then pacing. The trouble with atropine and pacing is that, and I suppose, well, not so much with beta agonists, but the problem with them is that they still aren't fixing the problem. They're fixing the problem upstream, which doesn't make sense, right? So we showed this before, the calcium depolarization, calcium influx. Atropine and pacemakers just cause depolarization. And so you're still trying to open up a calcium channel that's occupied. And so that's the reason. I'm not saying don't use them. It's perfectly reasonable, but that's the explanation for when you see a textbook that says pacemakers fail, atropine doesn't work. That's everything. Sometimes it does, sometimes it doesn't. And that's really the reason, is because they're really, really upstream of the calcium channel. So we kind of expect them not to work, but they may. And it all depends on how much they took and which drug they took. So the hypotension can be broken into 2 different groups. The first is vasodilation. And that, again, is that smooth muscle relaxation. Remember, the calcium coming into the cell is the calcium that causes the contraction. And so the treatment for that can be our typical alpha agonists like norepinephrine. I chose norepinephrine in this case, not phenylephrine, because norepinephrine I'm not worried about heart rate because usually their heart rate is slow. And so if we give lots of norepi, you'll get a little beta effect, and that's not a bad thing. This is not a case where the person's really tachycardic and hypotensive, in which case I would use phenylephrine. But calcium in these patients is really has a pretty high likelihood of working. And the reason is because you're increasing the calcium outside the cell. And so any calcium channel that happens to be open, even for a moment, you're basically causing hypercalcemia, and more calcium will flow in at any particular time. And then the secondary is depressed cardiac contractility. How do you know that? The only way to really know it is to either do invasive monitoring, like a PICO or a Swan-Ganz catheter, which we don't do very often anymore, or do a bedside ultrasound looking at the contraction. And if the contraction is poor, then we know that we have decreased contractility. And some of the things that will help with that are glucagon, amrinone, which I'll talk about in a second, which we don't use very often, but then obviously the common things like epi or other beta agonists and insulin and glucose. So as far as like the vascular smooth muscle, I was saying before, you add more calcium, any channel that happens to be open, you'll force a little bit more calcium through there. And any alpha agonists are bound to calcium channels and open them. And so you can force a little bit more calcium in there. And so all of those are ways to increase calcium, which causes the contraction, which causes vasoconstriction. Inside the myocardium, it's a little bit more complicated, but I think the key is, beta agonists stimulate the beta receptor, which increases CAMP, which leads to protein kinase activation, which leads to calcium channels opening. So it's sort of like yada, yada, calcium channels open. So that's what we want. And these are calcium channels that tend not to be bound by the calcium channel blocker. So glucagon theoretically does the exact same thing as beta agonists. And that's why we don't use glucagon very often with calcium channel blockers, because we can use beta agonists and they do the exact same thing. But glucagon bypasses the beta receptor and does the same thing that a beta agonist does. And then amrinone and milrinone as well as something that occasionally we would suggest in an ICU, which inhibits increases CAMP concentrations, which keeps the calcium channels open more frequently and more often. So you would have more calcium inflow and more contraction. All right. So again, just to kind of review some of the treatments, because we're going to go through the beta blockers in a minute, and a lot of the treatments are exactly the same, and I won't go over all the doses over again. I'll do them now. So atropine blocks muscarinic receptors. The dose is usually one for sort of a code situation is 1 milligram IV. And you can use lower doses. I think ACLS now recommends 1 milligram. They used to recommend 0.5, but there's sometimes a paradoxical effect. And so they've recommended higher doses now. Calcium is going to improve blood pressure more than heart rate, because it's going to cause that vascular smooth muscle contraction rather than the calcium influx into the myocardium. And so you see some doses up there with an infusion. I think that this would be aimed at someone with vasodilation rather than someone with a cardiac conduction abnormality or a cardiac contractility issue. We reviewed all of the catecholamines yesterday. Ebna again, makes no sense, but that's how I remember it. Epinephrine beta, norepinephrine alpha. In these situations, it doesn't really matter to me what catecholamine you use, because you could use both alpha and beta stimulation, so it doesn't really matter which one you start as far as I'm concerned. So, but epinephrine seems to be a good starting place for most of these things. And like I said, we don't use glucagon a lot for calcium channel blocker overdoses because you've got a perfectly functioning beta receptor to use. But when we talk about beta blocker overdoses, then this is the dosing. Typically, I wrote a kind of a low dose. Honestly, it should probably be more like 5 to 10 milligrams to start, but of course we never really actually have that much glucagon around, which is the major rate limiting step. And then amrinone, mostly an ICU drug. It's not going to be something that people in emergency departments are going to be very familiar with, nor have used before. But amrinone and milrinone are used fairly commonly, particularly in like cardiac units. And insulin and glucose, I think the important point about insulin and glucose is that its main effect is going to be increased contractility. It is not going to change the heart rate. It is not going to change the vasoconstriction or vasodilation. So that it won't change the systemic vascular resistance. It's only going to increase contractility. So if you have totally normal or hyperdynamic contractility, then it's probably not the drug to use. But if you do have decreased contractility, then beta agents and insulin and glucose are your primary. All right, so beta blockers, very similar in clinical effect to calcium channel blockers, pretty much the same treatment modalities. Obviously, calcium probably not as prominent for beta blocker overdoses, and glucagon is probably more logical in beta blocker overdoses than calcium channel blockers. And there is less of an issue with the pure beta blockers with vasodilation. So most of the effect is on the heart. It's going to be decreased contractility, decreased heart rate, less vasodilation, although there are some beta blockers that do cause vasodilation. So let's just look at a list of beta blockers. This is a classic grouper and splitter type of situation. They all inhibit beta activity or beta receptors. There's a small group of beta selective drugs. I don't think this is clinically particularly important. This is really important when you're treating someone's medical problem and they have severe asthma and you would like them to have a beta selective, a beta 1 selective. But as you all know, in large overdoses, all selectivity goes out the window. And so it doesn't matter much for us. So you can be aware that there are some that are very selective for beta 1, but probably not important in the overdose world. I should say the intrinsic sympathomimetic activity is another way that they group, and a lot of the newer drugs have this intrinsic sympathomimetic. What that means is that they aren't full antagonists. They have a little bit of an agonist effect. It doesn't make a difference in overdose, but I just wanted you to be aware that they are grouped that way. And then the membrane stabilizing has to do with the potential for QRS widening. And you see propranolol listed there, but a couple of others listed there as well, which we don't see very often in overdose. And then this is what I was mentioning before. A lot of the newer ones will have also some alpha effect. Classically, labetalol is both an alpha and beta blocker, much more beta blocker than alpha, but a lot of these other ones. This is not hugely important in overdose again, so I don't know that I would go spending any time memorizing this stuff. because it doesn't seem to really affect their overdose tremendously. There might be a bit more hypotension with carvedilol and labetalol than the other beta blockers, but you know, it's not gonna, and that would be vasodilation, and so I might treat things a little bit differently, but otherwise, I think they're about the same. Oh, and I just wanted to use there, this is from Goldfrank. If you're really interested in how specific they are, there's a nice um, there's a nice chart there. I don't think this is clinically super important, and I don't think they're gonna go asking you like, which of the following is a beta one specific? I think that would be an extremely mean and inappropriate question. So just like with calcium channel blockers, bradycardia and hypotension, unless it's carvedilol or labetalol or one of the other newer ones, there's no, there shouldn't be any vasodilation, but there may be from those drugs. So just like with calcium channel blockers, I think about breaking it into what the issue is. So bradycardia, if they are hypotensive from their bradycardia, the patient has a heart rate of 12 and their blood pressure is 60/30, it's not an unreasonable thing to assume that their heart rate is causing their blood pressure. I don't know for sure, but I'm just going to go ahead and say that that seems like a reasonable thing. So that person again would get atropine as a temporizing measure while you start an epinephrine infusion, or which is a beta agonist. The problem with epi or other beta agonists is that your beta blockers, your beta receptors are blocked. And so you can choose at that point to either try to overwhelm the beta blockade with more beta, in which case you're going to go to very, very high concentrations of epinephrine if they're very sick. Or you can use glucagon, and glucagon again kind of bypasses that beta receptor. On paper, glucagon is the perfect antidote for beta blocker overdoses. Unfortunately, I don't think all of us have been particularly impressed with its clinical utility. But I think if you got asked the question, what's the antidote for beta blockers? I think the answer is glucagon, because it certainly looks like it on paper. So the hypotension is usually going to be caused by decreased contractility. This is a great case for beta agonists, again, to try to overwhelm the beta blockade, and then also high dose insulin therapy to increase contractility. And if there's a well, I should note, high dose insulin, you have to be a little bit more careful with beta blockers because they don't have the insulin resistance that calcium channel blockers do, and they also may have a higher rate of hypoglycemia. Since calcium channel blockers cause hyperglycemia, it's usually not a problem, but with beta blockers, they may have a higher rate of hypoglycemia. You just have to be careful about that. And then if there's vasodilation, then, like if it's labetalol or carvedilol with their alpha effects, then I would consider using an alpha agent like norepi. All right, so we are moving on, doing pretty good on time actually. So if people have questions, then please pop them up in the chat. Digoxin or cardiac glycoside toxin. I'm going to talk about digoxin mostly. I'm not going to talk about plants, although I'm happy to, tangents onto plants if we want to. I think Zane is giving you a plant lecture later this afternoon, so I won't step on his material. So digoxin or cardiac glycosides in general block the sodium potassium pump. Sodium accumulates inside the cell. That increase in sodium causes a flip of the sodium calcium exchanger to push sodium out and bring calcium into the cell. The more calcium inside the cell, a couple of effects happen. One, you have more contractility. The more calcium floating around, the more gets stored in the sarcoplasmic reticulum. every depolarization, you release a lot more calcium. And that sarcoplasmic reticulum stored calcium is the stuff that causes the contraction. So this is the reason why DIG back in the day was used for heart failure. I know it's like very rarely used these days when you have an EF of 5% or something. But this is what it used to be used for. And now it's mostly reserved for control of AFib, and even that is getting less and less common. But what else happens when you increase calcium inside the cell? You have a much higher risk of calcium leaking out of the sarcoplasmic reticulum and causing a spontaneous depolarization. What that means is increased automaticity. In other words, a cell just fires all by itself without any stimulus. And that can lead to PVCs, but it also, if you string a lot of PVCs together, that's it's VTAC. And so that can lead to ventricular dysrhythmias, which is the reason why we don't use it for heart failure anymore, because the patients would essentially feel great and then they would die of sudden cardiac death. So even though their quality of life increased, their duration of life decreased. And so the other effect that DIG has nothing to do with the sodium potassium pump stuff that's happening in the heart. It does have to do with the sodium potassium pump, but probably in one of the sensory nerves in the neck that causes increased vagal tone. The increased vagal tone causes bradycardia and AV block. So all of these things together give us our classic digoxin toxicity. Now I put the question mark hyperkalemia there simply because hyperkalemia from digoxin is an acute toxicity effect that is not a chronic toxicity effect. What this was described in children who took large acute overdoses of digoxin, and remembering the mechanism of action makes it really clear as to what's going on. If you block enough sodium potassium channels or channels in pumps in your body, in all of the muscle cells in your body and your heart, then you are increasing the intracellular sodium and you are increasing the extracellular potassium. So the hyperkalemia that those children had after their acute DIG overdose was because they had blocked so many sodium potassium pumps that the potassium accumulated in their serum. And when their serum potassium was more than 5.5, they had 100% mortality, and that was all from ventricular dysrhythmias. So it is a really, really powerful sign, but the percentage of all DIG toxicity we see that are actually acute is tiny. So the vast majority of time we're seeing chronic DIG toxicity, which does not have so many sodium potassium pumps blocked that you get hyperkalemia. You do get hyperkalemia sometimes because of the renal failure that you got that caused the DIG to accumulate that gave you the chronic digoxin toxicity, but it's not a very reliable marker of mortality in those cases. So that's why I put the question mark there. It happens, but it's super rare. So this is one of the cases that I had of DIG toxicity. This was a chronic. This is a scary EKG, and that's the only reason I'm sharing it. So what do we do? What would you do for that person? I don't even know what heart rate is this. It's like, oh, good Lord, I have no idea. It's really, really small, really slow, 20s. So what are our options? Digoxin specific fab fragments. What are the indications? Severe symptoms. I think, an antidote that doesn't have an indication that says severe symptoms is, we should reconsider it, whether it's an antidote. If someone's having severe bradycardia, severe ventricular dysrhythmias, they should get, from digoxin, they should get digoxin specific fab. The criteria for the asymptomatic person with DIG are very, very high, and these are all based on acute overdoses. So if it's ever over 15, then you should give Digifab. If it's over 10 after distribution, you should give Digifab. And again, with an acute overdose, if that potassium is greater than 5.5, then we should give Digifab. So I think vast majority of the time when we are giving it, we're giving it because of these things, right? Bradycardia, or they're having some PVCs or dysrhythmias. What's the dose? Well, I took this out of Gold Frank. This is the formula, which is serum digoxin concentration times their weight in kilos over 100. So most of the people on digoxin will have, I don't know, it always seems like they're 50 kilos. Probably because of, wasting, because they have AFib and CHF. But so it's roughly going to be, let's say your serum digoxin concentration is 4, and their weight is 50 kilos. It's going to be 2 vials. So it's kind of roughly half of their digoxin concentration. But I know that you have formulas on your tests, and I suspect that this one might be one of those that you have to calculate. I also put down the ACLS recommendations for if you know that they're sick and it's DIG, but you don't know how much they took. I will just say that these are enormous. 10 to 20 vials and 3 to 6 vials is a lot, and we're not recommending this, but this is what ACLS currently says. The reason we don't recommend 10 to 20 vials is because there's some pretty good literature that says that 2 vials will bind all of the intravascular digoxin up to, it's actually above, there was actually a patient with a 13, I think, in that group, and all of their digoxin was bound by 2 vials. So currently we're giving 2 vials and then waiting and seeing, and if you don't have a response or you have a partial response, then you can redose that. But that's us, and the recommendations from ACLS are 10 to 20 vials. So just want to let you know that in case there's a question on it. I think you go with the ACLS answer, which is 10 to 20 vials. The other reason we don't recommend 20 vials is because 20 vials is about $100,000. So, and most of it gets urinated out unbound in the urine. So it makes it's a lot better resource use, and it's better for the patient to use 2 at a time. All right. So ventricular dysrhythmias, lidocaine. So first of all, Digifab, right? I should have put that in there because if they're having ventricular dysrhythmias, you should be giving them fab fragments. Unfortunately, the onset of effect of Digifab is very slow. The onset is at least 24, 25 minutes. The peak is several hours, and it kind of makes sense. Remember, Digifab is essentially like a chelator. It's binding Dig. The problem is those 2 vials you give will get rid of they'll bind all of the digoxin in the blood, but there's still digoxin in the end organs, and they very slowly distribute back into the serum. And so the heart effects are going to be there for a while, and you're not going to see a resolution of those heart effects because the digoxin concentration in the heart is very slowly going down. So it's not like naloxone, unfortunately. It does kick in, but it's going to take a while. And so if someone's having a ventricular dysrhythmia, Digifab, but then also treat them. Lidocaine is the best studied, and since amiodarone causes bradycardia, I tend to stick with lidocaine. There is a tremendous amount of research done on phenytoin, believe it or not. Back in the day, that was used as an antidysrhythmic. It acts just like lidocaine, so anything you ever see about phenytoin, I just insert the word lidocaine instead of phenytoin. But I think that lidocaine is probably the drug of choice for these dysrhythmias. And then, of course, replete electrolytes. Hypokalemia makes digoxin toxicity worse. Hyperkalemia is associated with increased mortality. And again, with the hyperkalemia, it can be tricky. If it's an acute overdose, a child ate, 30 tablets of digoxin and now has a digoxin concentration of 8 and has a K of 6, I would assume that that child has digoxin toxicity with hyperkalemia because so many of their sodium potassium pumps are blocked that their K went up. And that patient should be treated with Digifab for their hyperkalemia because it's a sign of severe toxicity. If you have a 85-year-old who's on digoxin and is taking therapeutic doses of digoxin but got sick and got dehydrated and now has a BUN and creatinine of 80 and 4 and a digoxin of 2.3 and bradycardia with a K of 6, that person is hyper K because of their renal failure. And so we would treat it just like any other hyper K from renal failure, fluids to get rid of their renal failure. But then if it's really high, insulin, albuterol, hemodialysis, all of those types of things, rather than necessarily Digifab. I don't know if that makes sense. All right. Very good. That's all I have on that group of meds. Questions? Hey, Zane. So question about digoxin and hemodialysis. Unfortunately, you can't really clear digoxin very well with hemodialysis. It's too big a molecule. So no. You can remove it in very unusual circumstances, like with Digifab when they have actual renal failure. You can do things like plasmapheresis or exchange transfusion to get rid of it. But yeah, so we would not use HD for the dig itself, just for the renal failure or the hyper K from renal failure. All right, very good. Well, Zane, I don't know if you want to start at 1 or we're 10 minutes early. If you want to start early, or I don't know I don't want to ruin anyone's plans. Extended lunch might be a happy thing.
Oh, I think Zane, you're muted if you're trying to talk.
Oh, yeah, I just joined like the last 15, 20 minutes. Did you do the sedative hypnotic ones already?
I think he switched.
No,
He
I'm
did
muted.
sedative hypnotic
Yeah.
first and then cardiac.
All right.
Yeah, sorry about that. I switched it around because it didn't work with breaks. We wanted to have a break every hour.
All
So
right. So if I'm up, I can start early to get through everything on time. If people are interested in coming in at 12:30 or 12:45, let me know. I'll eat quickly and be back.
I see head nods. Is there anybody that can't be back at? Do you want to shoot for 12:30? Is that a long enough break for people? Can everyone be back at 12:30? If you can't, it's okay. We can. Everyone's nodding. Yeah. Okay. So let's start back up with Zane at 12:30.
All right. We'll see you all then. Have a good lunch.
Thanks, Rob.
Yep. Thank you.